Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're talking about something called a pulmonary embolism. Most of the time, you'll hear people call this a PE. So as always, let's jump right in with our question. Here we go. A nurse is caring for a client who is post-operative day 2 following a total knee replacement. The client suddenly reports a shortness of breath and a sharp chest pain that gets worse with every deep breath. On assessment, we have the following vitals: a heart rate of 122, respirs at 30, BP of 98/60, and an O2 saturation of 88% on room air. And lastly, a temp of 37.6 Celsius. So which action should the nurse take first? We have A, administer oxygen via a non-rebreather mask. B, encourage the client to use their incentive spirometer. C, prepare to administer a prescribed anticoagulant. Or D, obtain a 12-lead ECG. Okay. Go ahead and think through, shout your answer out loud right now, and we will circle back at the end to see if you got that right answer and make sure you understand why. But first, let's do a deep dive into what a PE actually is. A PE is a big deal for a couple of reasons. First and foremost, it is heavily tested on your NCLEX, and in real life, it is a situation that can go from a client seeming like a little short of breath to a code blue in just a matter of minutes. So let's drill into it, make it easy so we really understand what's going on. In one sentence, a pulmonary embolism is a clot that gets stuck in the artery of your lungs and blocks blood flow. That's it. It's honestly that simple, but we need to unpack why a clot in that area is such a problem. The picture I want you thinking of is like your lungs are a big city, and the pulmonary arteries are the freeways that are bringing traffic into that city. The traffic is your blood, so every car is zooming down those freeways, and it is carrying oxygen. It almost is like an Uber driver. It picks up oxygen, it carries it out to the tissues, and drops off carbon dioxide as it flows back to the lungs, and we want to exhale and get rid of that carbon dioxide. So as long as the roads are open, traffic is flowing, the city runs. That blood flows, it gives the oxygen, it comes back to the lungs, delivers that carbon dioxide. We are all happy. But if a clot is present, let's say we have a clot somewhere else in our body, it breaks loose and it travels up to the heart. Then it gets shot out into the lungs and bam, wedges itself into a pulmonary artery. That clot is equivalent to like a massive 10-car pileup right there on the freeway. Our traffic is going to slam to a stop. Now, behind that pileup, the cars are stacking up and nothing can get through. Past the pileup, that whole section of highway, it is still wide open for business. So that part of the pulmonary artery forward of the clot, it is still open and it's still getting air, which means your client is still breathing. There is part of the lung that is still ventilated, but that part behind where that clot is, where our 10-car pileup in the freeway is not getting blood. There are no cars to actually pick up the oxygen and drop off carbon dioxide. So this leads to the classic finding of a PE, which we call our VQ mismatch. V stands for ventilation, and Q stands for perfusion. That is when our blood is getting to our tissues, perfusion. So we've got the ventilation part. We're still breathing, getting oxygen into the lungs, but we are not perfusing. So we don't have the Q part, and that's why we've got a mismatch between the V and the Q. It's also what leads to the biggest clinical sign here, which is our client's oxygen tanks, even though they're breathing as hard as they can. Breathing, ventilating, but they're not perfusing, so that oxygen tanks. All right, let's kind of put the pieces together here and go through that sequence of events. We get a clot. Let's say it was from a DVT in the legs. It breaks off. It goes to the lung. That clot blocks our pulmonary artery, and then blood cannot reach that part of the lung. The clot is that 10-car pileup. It is blocking traffic on the freeway. And once that has happened, oxygen cannot get picked up. Blood is then backing up, and it's going to cause strain on the heart, specifically on the right side of the heart where blood is trying to get out of that right ventricle and go to the lungs. Well, that's where we have our 10-car pileup in that pulmonary artery. So blood is backing up the right side of the heart's trying to get it out, and it can't. So one more time, we get a clot, it blocks the artery, no blood flow, no oxygen pickup. We are putting strain on the right side of the heart. You see how the dominoes just fall here. One little thing, one clot, and it has caused a catastrophe. Because when we're putting strain on the right side of that heart, that is what ultimately ends up making a pulmonary embolism potentially deadly. Your right ventricle is trying to pump blood into a traffic jam, into a set of lungs that literally are blocked. So that pressure gets really, really high. The right ventricle obviously is going to be super overwhelmed by that. And if that clot is big enough, the heart just won't be able to push against it. So then our blood pressure will drop and we are in obstructive shock. All right. That's the version of a pulmonary embolism that kills people, and you have got to know the signs of it. So what are you going to see at the bedside? What are those signs? There is a classic combination of symptoms. Once you have seen it once, you will never forget it. The first thing you're going to see is sudden shortness of breath. And the key word for you is sudden. They are breathing fine 1 second, and then they just cannot catch their breath. That happens because the clot comes on suddenly, breaks off from somewhere in the body, shoots over into the heart. The right ventricle pumps it out into the pulmonary artery. So all of a sudden, those lungs are blocked. We get the VQ mismatch, and our oxygen saturation plummets. So they're going to be short of breath. It's going to happen really fast. They're also going to have sharp chest pain that gets worse when they breathe in, which makes sense, right? Like they're trying to ventilate these lungs that aren't getting perfused. That hurts. We call that a pleuritic chest pain that is worse when they breathe in. They're also going to be tachycardic, tachypnic, and desaturated. That's a really key thing to watch when those oxygen sats drop fast. And that can also cause anxiety. One of the most crystal clear signs in my mind of a PE is when someone says they have this sense of impending doom. Like they know something is wrong. They can feel it. You might not see it showing up yet, but you are about to. That is their body telling them they are not getting enough oxygen, and they will be able to tell you something is wrong before the monitor can. Now, when you go to assess them, there is one thing that I never thought made sense till I really put all the pieces together. You would think like, hey, this is a huge respiratory issue. I listen to your lungs. I'm going to hear something. But their lungs usually sound clear because there's not a bunch of phlegm or clogs. This is a perfusion issue. The alveoli, bronchioles are totally good. So you're not going to get wheezes and crackles and rales. The lungs ventilate. They are just not perfused. VQ mismatch, dropping sats. They have anxiety because they can't catch their breath. They are breathing as fast as they can, but they are not getting oxygenated. So if you see clear lungs and terrible oxygen saturation that just came on suddenly, that should be a big red flag for you for a potential PE. Now, who is going to get a pulmonary embolism? There are some clients that are just way more likely, and there's actually something called Virchow's triad that gives us our 3 biggest risk factors. When all 3 are true, we know there is a high risk for a PE. The first bucket is blood that's sitting still. So think like immobility in a post-op client, someone who has been on a super long flight, or your client who is bedbound. The second bucket is blood that just clots too easily. Anyone who's in a hypercoagulable state. That's going to be things like cancer, pregnancy, or a client who is on oral contraceptives, those birth control pills. The third part of Virchow's triad is going to be damage to the vessel wall. So any injury, maybe it's surgery, a trauma, a fracture, we damage that vessel wall, that can cause a clot as well. All right, so 3 buckets: Virchow's triad, blood that's sitting still, blood that clots too easy, and damage to the vessel wall. You get those factors, and that's what puts a client at risk for a PE. So that being said, let's kind of walk through a quick little case here on what a PE can look like. We have got a 34-year-old who is postpartum day 3 from a scheduled C-section. She is actually getting ready to be discharged. About 72 hours after that C-section is pretty typical. And when you go in for your morning rounds, she hits her call light. She tells you she feels weird. Can't catch her breath. All right. Can't catch her breath. Feels weird. Postpartum. We know it's hypercoagulable. She also just had surgery from a C-section. Alarm bells should be going off for, okay, something is up. She has some of those risk factors in Virchow's triad for a PE. Feels weird, can't catch your breath. That is always something you take seriously. So go in the room. What's she look like in our case here? We've got her sitting up, breathing really, really fast, leaning over like she's trying to catch her breath, and that look of impending doom. That tells you all you need to know. Get her on the monitor, press that call bell, and get someone in the room who knows more than you do. When you get her on the monitor, here are the vitals we've got. Heart rate of 128, respers of 32. BP is holding at 100/64, and she is satting 86% on room air. You listen to those lungs, and they're clear. Normal sounding lungs. We don't have wheezes. We don't have, crackles or rail or anything, but clear lungs, and suddenly an oxygen saturation in the 80s. What are we thinking? We are thinking a PE. We don't have a problem with the lungs getting air in and out. We have a problem with blood getting to the lungs. That perfusion ain't happening. And it should really click for you when we've got a client who is postpartum. They're hypercoagulable. They've just had a surgery, a C-section that introduced damage to the vessel wall. And they've been sitting in bed for, about 3 days. They're newly postpartum surgical. That post-op client's not going to have great mobility. Those are all 3 components of Virchow's triad. So you should be watching them like a hawk for any signs of that PE. And this is the classic picture. So what are you going to do about it? It's an emergency. This could kill her if you do not act fast. Your priority is going to follow those ABCs. She's got an airway. She's breathing. She's ventilating oxygen into her lungs, but her lungs are not perfused. That oxygen being low is a B for breathing priority, and you need to act quickly. Get a non-rebreather, 100% high flow oxygen, and sit her up. A little mnemonical memory trick that we use sometimes for positioning. In PE, we pull the head of the bed up. We want to sit her up as much as we can and get that oxygen going, okay? Now hit that call bell and get someone in there. We are likely going to need to get some imaging really, really quickly to figure out what's going on. 2 types of kind of testing that you might hear about in this situation. The first lab is a D-dimer. That is a lab that is going to look at your blood clotting. Now, it's great to tell us if we have a clot going on in general. If it's high, clot, low, probably don't have a clot. But it's not going to tell us for sure where that clot is, and we can't rule it out, okay? If it's low, we're like, okay, it's not a PE. We don't have a clot going on. But if it's high, that just tells us, okay, yeah, she probably does have a clot. The gold standard for actually confirming a PT is going to be a CT angio. We're going to use the contrast dye. We are going to see that clot in her lungs, okay? So that is what will actually confirm it. when we have the time to do so. We first got to get that oxygen on her to stabilize her. And then where do we go from there? We confirm that it's a PE by getting that CT angio. All right, we've got oxygen on her, but we have to address that clot. Now, if you've got a client that's stable, anticoagulation, that's going to be the cornerstone of treatment. Usually it's going to be heparin. We'll start an IV, do that heparin infusion. We're going to titrate that dose. And then eventually we're going to get that client onto enoxaparin so they can be discharged home on that, because they're going to need long-term anticoagulation here. But heparin, it only stops a clot from getting bigger. It's not going to bust up a clot that's already there. For that, we need our clot-busting drugs like Altplace or TPA. If your client is not stable and they've got that PE, we are going to be giving that clot-busting drug as fast as we can to break that clot up. And if that's not fast enough and they're still not stable, we need to go off to the OR to actually physically remove that clot. That procedure is called an embolectomy. So embolism is the clot, ectomy, we're going to get it out there, right? Anticoagulation prevents. Thrombolytics like Altplace TPA, they dissolve. Embolectomy surgery, that is just physically, we are going to scoop that clot right out of there, okay? So which one of those you do depends on how stable the client is. If it is a true emergency, we're not getting no oxygen to those lungs, that PE is blocking the whole pulmonary artery, you can bet we are going to the OR immediately to save that person's life, okay? Now, let's go back to our case study here. We got our CT angio. We saw it was a PE. We have already got that oxygen on her. Now, this client stabilized on anticoagulation and oxygen. She got to go home. She got to live a great life with her baby. But there is another version of that story where we have such a massive PE. That clot is so big and the blood pressure crashes. That client goes into obstructive shock that we have to rush to the OR. It is a true emergency that you cannot take for granted. You need to act fast. Your nursing priority is to get that oxygen on them and then get the provider in the room so we can assess what that definitive treatment is going to be. Okay, with that being said, let's circle it back to our practice question and see now if you can get the right answer and understand why. We have a nurse caring for a client post-op day 2 following a total knee replacement. They suddenly report shortness of breath and a sharp chest pain that gets worse with every breath. That's that pleuritic chest pain. On assessment, the nurse notes a heart rate of 122. Respers are at 30 and a BP of 98/60 with O2 sats at 88% on room air, and the temp is 37.6. What action should the nurse take first? So prioritization, what do you do first? Administer oxygen via the non-rebreather. Encourage the client to use the incentive spirometer. Prepare to administer the prescribed anticoagulant or obtain a 12-lead ECG. Now, go ahead and say it out loud because I really do think you know the right answer now. This client is showing us classic PE symptoms, a sudden shortness of breath, pleuritic chest pain, they're tachycardic, tachypnic, and desaturated on room air. That SAT of 88, that is the emergency. And when you're picking your priority, remember, you're following your ABCs, airway, breathing, circulation. We have got a problem with getting oxygen to these lungs. So what are we going to do? We are going to give oxygen. Giving oxygen first, using that non-rebreather, that's your priority in a pulmonary embolism. So to wrap it up, let's say it together one more time and make sure you know what's going on here. A PE is a clot that blocks the pulmonary artery. It goes to those arteries in the lungs, and that stops the blood from reaching the lungs. Therefore, it can't pick up oxygen, and it's putting strain on that right heart. The classic signs that it's causing are that shortness of breath, that pleuritic chest pain, and all of a sudden they are really desaturated, even though their lungs sound clear. They can ventilate, We're just not perfusing those lungs, which means what's our priority? Give them oxygen. Clear lungs, crashing oxygen saturations, think PE, and give that oxygen first. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.